I would have to say, I'll start out by saying it's been very humbling listening to the conversation. And I feel like a pointy-headed bureaucrat and very much not in step with the current thinking. But I did want to defend why we do the things we do a little bit. It is very difficult to conduct like a placebo-controlled long-term trial. There's a lot of patient dropout. With a lot of the longer trials, we can't get very interpretable data. So that's one reason why we tend not to conduct very long, at least placebo-controlled trials. As you know, when we were looking at the toxicity of NSAIDs and COX-2, we did run long cardiovascular outcomes trials, but those were always active controlled. The safety is more difficult to understand, and obviously you don't get a lot of conclusive efficacy data out of that. So that's one thing. With regard to the endpoints that have been discussed, I think we in our division, I think, are willing to look at anything. Like one thing that I see once in a while on typically on phase 2 OA protocols now is actually actigraphy. And I am very curious to see what that's going to show, because I am aware that some patients might actually, their pain might be the same at baseline as it is at the end, but they were more active. And so their quality of life is better. So I'm very interested in seeing a lot of these other things, but the focus has always been very much on, in the philosophy in the division has always been that sponsors need to demonstrate an effect on pain. They didn't want it to be confounded with other things that had gone. I mean, our old 2 division directors ago, I had this discussion with him. He didn't want us to be making decisions because somebody won the lottery, and when they went in for their visit, they reported less pain. So it's very interesting. Thank you for all the conversation and all of the comments. It's always so important to hear the patient perspective. And so I'm obviously, our management is on the call, and so we will take all of this back. But I did want to explain that is why my presentation, we sound so rigid and old-fashioned, and like we're not aware of what's going on. We are. It's just hard for us to change. And like we're stuck with the WOMAC because that's considered a validated endpoint in OA trials. And so therefore, in order for regulatory decision making, that's kind of what we're stuck with. Thank you.